Hello, everybody. We'll continue our class on disorders of WBC, the third lecture. As my daughter decided not to share her crayons with me because I broke one of her crayons in the last class, WBC2, you won't have to endure my horrible drawings or my handwriting today. Okay, come on. I hope you guys remember where we were. We are in lymphoid neoplasms. We have seen peripheral B cell neoplasms, T and NK cell neoplasms, plasma cell neoplasms, and now it's time to go into Hodgkin lymphoma. Hodgkin lymphoma is named after Dr. Hodgkin, who was working along with one Dr. Addison and Dr. Bright. They found out similar clinical findings in 7 patients, and this specific type of Reed-Steinberg cells, which are hallmark of Hodgkin lymphoma in the blood. This is a very important event in pathology because probably it is from this event that pathologists started working along with other clinicians for the diagnosis of diseases. Look, non-Hodgkin lymphoma is called so because it's not Hodgkin. The main differentiating factor is Reed-Steinberg cell. Reed-Steinberg cells are large neoplastic cells seen in Hodgkin lymphoma. But there are other important differences between the two. Hodgkin lymphoma is most often localized to a single group of nodes. NHL can occur multiple nodes across the body. Hodgkin has a very orderly and predictable spread, and it spreads it has a contiguity, spreads from one group to a nearby group. NHL can spread weirdly all over the body. Mesenteric and Waldeye's ring, for some reason, is rarely involved in Hodgkin lymphoma, and Hodgkin is almost always nodal. Extranodal presentation is rare. That means it occurs in lymph nodes. These are some features of Hodgkin lymphoma. It is postulated that the RS cells or Reed-Steinberg cells originate from the germinal center or post-germinal center B cell. But the funny thing is, it fails to express most B cell specific genes. So, and even immunoglobulins. And most important pathogenesis occurring here is activation of NF-kappa B. And many tumors have Epstein-Barr virus positive. EBV induces LMP1, which causes increase in NF-kappa B. Now, diagnostic RS cells are large cells, like about 45 micrometer in diameter, with multiple nuclei or a single nuclei with multiple nuclear lobes, each having inclusion-like nucleoli about the size of a lymphocyte. Nucleolus is about the size of a lymphocyte, and sometimes it's called as the nuclei are called mirror images of each other. In Hodgkin's lymphoma, Uh, the malignant cell is the Reed-Steinberg cell, but almost 90% of population or the mass of the tumor is composed of reactive cells, which may include monocyte macrophages, eosinophils, and other reactive lymphoid population, polymorphous lymphoid population. So, like, why is it so? It is because of the cytokines produced by the RS cell. Like various chemokines are produced, which enhance Th2 T cell response. Interleukin 10 is produced, which suppresses cytotoxic T cell response. Interleukin 5, as we know, increases eosinophils, tissue eosinophilia scores, and in turn, eosinophils produce CD30 ligand, which binds to CD30 and increases NF kappa B inside the RS cell. Like that, T cells produce CD40 ligand, which increases NF kappa B. Again, RS cells can produce tumor necrosis factor alpha and beta FGF, fibroblast growth factor, and cause increase in fibroblasts, which causes fibrosis. This fibroblasts produce eotaxin, which also increases eosinophils, and MCSF increases monocyte activation. So the RS cells are required for the creation of these reactive background cells, and all these reactive background cells are required for the survival of RS cells. So it's a symbiosis here. This is the microscopy of RS cells. There are different types of RS cells. They occur in different types of Hodgkin. This is the classical diagnostic RS cell. The nucleus has two lobes, and the nucleoli are pretty prominent. These eosinophilic large lymphocyte sized things are the nucleoli. Reed-Steinberg cell, mononuclear variant B. There is only one lobe, and nucleoli are very prominent. This one. C. RS cell, lacunar variant. It seems like the RS cells, the nucleus is lying in a lacunar space, as though there is no nuclear membrane or cytoplasm around it. It is due to the fragile nature of these cells, the lacunar cells, and it's a cutting artifact kind of. When histo sections are cut, the cytoplasm is stripped off. And D is lymphohistiocytic variant. It's also called popcorn type of nuclei. You can see this. Now coming to the subtypes of Hodgkin lymphoma. Hodgkin lymphoma is broadly divided into two: classical and NLPHL, or nodular lymphocyte predominant. So classical Hodgkin lymphoma includes these four types: nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depletion. This is non-classical, nodular lymphocyte predominant, NLPHL. Now, nodular sclerosis is the most common Hodgkin. Nodular sclerosis frequently has lacunar cells and very occasionally diagnostic RS cells. Background is reactive, can contain lymphocyte, eosinophil, macrophage, plasma cells, fibrocytes, fibroblasts, and the fibroblasts here are important. They form fibrous bands which divide the cellular areas into nodules. Another thing is, this is immunohistochemistry. When you do the immunohistochemistry of lymph nodes or flow cytometry, all the classical classical types are CD15 positive, CD30 positive. CD15 and CD30. All the classical RS cells in all classical types are CD15 and 30 positive. But NLPHL, CD15 is negative and CD30 is negative. EBV can be positive or negative depending upon the nodular sclerosis usually presents in stage 1 or 2 of the disease. We'll go through stages later in the lecture. Most patients are young adults. Now coming to mixed cellularity, frequently mononuclear and diagnostic RS cells. Background is again mixed. 70% are EBV positive. Here many present in stage 3 or 4. Again it peaks in young adults and then after 55 years, kind of a biphasic incidence. We'll see in many places that they would have written Hodgkin has a bimodal kind of age distributions because of this. Lymphocyte rich Hodgkin lymphoma, classical Hodgkin. Here again mononuclear and diagnostic RS cells can be seen. Background is mostly lymphocytic, T lymphocytes. EBV may be positive. Here it tends to occur more in older adults. Now lymphocyte depletion. Here you see diagnostic RS cells, and there is paucity of background reactive cells. That's why it's called lymphocyte depletion. This is uncommon, but it occurs in older men or HIV infected individuals, and it often presents as advanced stage disease, difficult to treat. Now coming to non-classical nodular lymphocyte predominant Hodgkin lymphoma, NLPHL. Here diagnostic RS cells are rare. Mostly popcorn cells are seen, or L and H variety. And background consists of dendritic cells and reactive B cells. Here RS cells are CD20 positive, CD15 negative, CD30 negative, and EBV negative. This is uncommon. Occurs mainly in young males. Although it recurs more frequently, it is easier to treat. We'll go into the patients with nodular sclerosis or lymphocyte predominant types tend to have stage 1 or 2 nodular sclerosis or lymphocyte predominant, and mixed cellularity and lymphocyte depletion present at higher stages, and they are more likely to have B symptoms: fever, night sweats, and weight loss. Anergy can occur in Hodgkin lymphoma. It is basically due to its ability to inhibit immune response. The spread of Hodgkin lymphoma is very very predictable, stereotypical. It affects nodes first, then the next group of nodes, then goes into the spleen, then liver, and finally the marrow and other tissues. We'll go into the microscopy. Nodular sclerosis type of classical Hodgkin. Like we have seen, it is called so because of this nodular appearance of the lymph node, and you can see sclerosis here. The pink staining areas are basically fibroblast proliferation. So these are the these fibroblasts are the one which are giving it that nodular appearance, and that's why it's called nodular sclerosis type. There are Hodgkin cell RS cells in there, and background is reactive. We cannot see it over there because it was low power. It was a low power image. Coming to mixed cellularity type of classical Hodgkin. Here you can see diagnostic RS cells, binucleate RS cells with very prominent nucleoli. If you see the background cells, you can see these are all lymphocytes, and these orangish red ones are eosinophils, all reactive proliferation of eosinophils. A few macrophages here and there. So in mixed cellularity type, you see diagnostic RS cells. Coming to lymphocyte predominant type, here you can see lymphohistiocytic variants or popcorn cells, these ones. Again, background is mainly consists of lymphocytes and occasional macrophages. The treatment of Hodgkin is mainly based on staging, an old classification or the Ann Arbor classification. It can be used in NHL also sometimes. Okay, here stage 1 is involvement of a single lymph node region, not single lymph node region, like this. And if it's a single extra lymphatic organocyte, it's written as 1E, extra lymphatic. Stage 2 is 2 lymph node regions on the same side of diaphragm, similarly 2E. 3 is when there is involvement of multiple lymph node regions on both sides of diaphragm. And stage 4 is when there is diffuse involvement of extranodal site. Now all these stages are further divided into A or B depending upon whether there are B symptoms, like unexplained fever, drenching night sweats, and weight loss greater than 10% of body weight over the past 6 months. Okay, now that we have completed lymphoid neoplasms, these are some takeaway molecular points. You would be familiar with this circle, would have seen it in neoplasia. So all the hallmarks of tumor are present in many of the many of the lymphomas. So I think I'll just go through the important ones. Hodgkin lymphoma, PD-1 ligand gene amplification. So there is how like they'll avoid immune destruction. This is important in therapy of Hodgkin also, because some resistant Hodgkin can be treated with PD-1 ligand inhibitors, which will increase immune destruction of RSLs in Hodgkin. Mantle cell lymphoma, cyclin D1, it's important. It increases proliferative signaling. Burkitt's, we have seen mic translocation. Follicular lymphoma, of course, BCL2 VSO. It prevents apoptosis. Then enabling replicative immortality in ALL, multiple mutations. This one is important. We saw earlier, marginal zone lymphoma, maltoma, etc. Like they are antigen dependent, or increased inflammation finally produces these tumors. Okay, finally we are through lymphoid neoplasms. We'll concentrate on myeloid neoplasms next. I hope you've not forgotten why they were called myeloid and lymphoid neoplasms in the first place. The stem cells can give rise to myeloid or lymphoid series. From myeloid series, everything except lymphocytes are formed. So, myeloid neoplasms can be broadly categorized into AML or acute myeloid leukemia, MDS or myelodysplastic syndromes, and MPN, myeloproliferative neoplasms. AML is basically proliferation of blasts, myeloblasts in the bone marrow, spilling into the blood. MDS, myelodysplastic syndrome, is caused due to ineffective production of myeloid cells, which finally causes cytopenias. And MPN is due to increased production, or usually there is block in myeloproliferative neoplasms. There is increased production of a particular cell. It's usually due to a block in development of myeloid progenitors. Acute myeloid leukemia. AML is a tumor of hematopoietic progenitors caused by many different types of mutations, which finally causes accumulation of myeloblasts in the marrow. These myeloblasts replace the normal elements of marrow, because of which there is marrow failure and complications related to anemia, as erythroid synthesis is affected, thrombocytopenia, platelets are not produced, and neutropenia. Again, just so that we don't forget where we are, acute leukemia can be ALL, which is common in children. And where did we see ALL? ALL is basically precursor B or T cell neoplasm. Okay. I hope everybody remembers ALL. Now AML is more common in old age when compared to ALL, and both of these things, since they are proliferating in the bone marrow, can interfere with development and function of other cells in the bone marrow. Okay, great. We'll stop today. We'll continue with myeloid neoplasms in the next lecture, and we'll quickly go through spleen and thymus also. Okay, thanks a lot, everybody. Do go through the MCQs given. Thank you.